Okay, so for this deep dive, we're really trying to unpack what even defines mental health.
Yeah, this slippery thing.
It really is. We're looking at the official guides, the policy shifts, and the whole dynamic nature of it. I think we have to start with the big one, right? The DSM-5.
The blueprint, absolutely. It's the standard language for clinicians, for researchers, insurers.
But that's the core question, isn't it? If we have this standard, why is it still so hard to, draw a clear line between what's health and what's illness?
And that's where it gets really fascinating. Because the sources are pretty clear. That line doesn't really exist. Not a static one, anyway.
It's not fixed.
Not at all. Psychiatry's definition,
Yeah.
it breathes with the times. It
Yeah.
reflects cultural norms, society's expectations, even politics.
Wow. So it's not just a purely scientific document then.
Exactly. I mean,
Yeah.
think about it. The sources point out that at different times, women who worked outside the home were considered mentally ill or homosexuals.
Yeah. That really shows how much it's about social context, not just biology.
Far more than just biology.
So, how does a clinician even begin to weigh all that? You've got this long list of moving targets. I mean, you're talking biological things like,
Genetics, hormones, yeah.
right, but then there's the environmental side, poverty, impaired parenting.
And spiritual, religious, cultural influences. It's this huge spectrum. You have to see all of it to get why these disorders are such a massive burden on the system.
And that burden is very, very real. I mean, look at major depressive disorder. The sources say it's the leading cause of disability in the U.S.
And it hits women almost twice as often as men.
It's not just mood disorders either. We see it in anxiety conditions. Something like 1 in 3 people with panic disorder ends up developing agoraphobia.
These are real, measurable, impactful health conditions.
So given all that, how did the law,
Yeah.
how did policy finally catch up and say, okay, we need to treat this equitably?
That brings us to parity. That was the huge shift. You had the Mental Health Parity Act back in '96, but the real game changer was the Affordable Care Act building on top of that.
Okay, so what did that actually do for you or me or anyone listening?
Well, functionally, it meant insurers couldn't just cap your mental health benefits with these tiny annual limits while letting physical health coverage be unlimited.
Got it. And it got rid of pre-existing condition exclusions, which is huge for chronic conditions.
Absolutely critical,
Right.
especially for things with strong biological links, schizophrenia, bipolar disorder, OCD, panic disorders. These need serious ongoing medical care.
Okay, so the legislative battle is sort of won. Treatment is covered equally on paper, but there's still this gap, right? A huge barrier to people actually seeking help.
There is, and that gap, that barrier, it's stigma.
Right.
Even when we know these are biological conditions,
Mm.
stigma just stops people in their tracks. It's
Yeah.
this negative stereotype that paints someone with a mental illness as, I don't know, inferior or unstable or dangerous.
And it's more than just a passing bad thought, isn't it? There's a whole process.
Exactly. The sources call it a psychosocial process. It starts with stereotyping, then labeling, then separating people into us and them.
Which leads to actual discrimination.
Right. Status loss, discrimination, all in a context where there's a power imbalance. That's what keeps people from using the protections that are legally theirs.
So we've covered a lot of ground. The official guidebook, the DSM-5, the fact that the definitions are always shifting, the huge policy wins, and then this persistent barrier of stigma that just undercuts everything.
Yeah, and I think what it all comes down to is the DSM-5 is the tool for diagnosis, sure. But culture has this profound influence on everything. How you see symptoms, how you coach, whether you even ask for help.
And the manual even tries to account for that, right?
It does. It has sections on cultural variations for each disorder. It describes these so-called culture-bound syndromes. It's trying.
So here's the final thought for you to chew on. The official guide is trying to be universal, but it's constantly wrestling with these very local, very specific effects of culture. So think about your own context, your background, your community. How might that influence the way you or someone you know sees certain behaviors or even makes that decision to reach out for help? That's the dynamic we're all living in. Welcome to the deep dive. So today we're jumping into something huge.
Yeah.
We're trying to quickly get a handle on the foundational theories of mental health care, starting, way back in the late 1800s.
Right.
The whole mission here is to trace that core idea that if we can understand the mind, we can treat it.
And it's a really clear evolution when you look at it. We move from these purely psychological ideas to, biology and modern nursing models. It's a sprint from the couch to the cortex, really.
Okay, so where do we even begin, I guess, with the biggest name in the game, right? Freud.
Has to be Freud. His psychoanalytic theory.
He basically gave us the first real map of the personality.
Mm-hmm.
You've got the id, which is just that primitive pleasure-seeking part,
Then the ego, which is, reality, the problem solver.
and the superego, your moral compass.
Exactly. And his therapy was all about digging into the unconscious mind.
Which is why we still talk about transference, isn't it?
We do. That's when the patient's feelings get redirected onto the therapist. And countertransference is the therapist's reaction back. It makes the whole thing a really dynamic interaction.
And that dynamic interaction, that leads right into interpersonal theory.
Yeah, which basically says all our behavior is just trying to do two things.
Get our needs met and avoid anxiety.
And it all happens through our interactions with other people. The therapist here is a participant observer, not just a blank slate.
This focus on interaction and, well, action. It seems like a direct line to the behavioral models.
It is. You get Pavlov and his classical conditioning.
It's Skinner with operant conditioning.
The big idea here was, look, if a behavior is learned, it can be unlearned.
So that gave us practical tools like systematic desensitization for phobias,
Exactly. But then we hit another huge shift.
the cognitive revolution.
And Aaron Beck's cognitive behavioral therapy, CBT.
Right. So now it's not just about what you do, it's about what you think.
I mean, that's the whole goal of CBT, right? To get in there and modify those negative automatic thoughts.
Those cognitive distortions that just send you spiraling.
You're basically fixing the flawed wiring in the brain.
And this is where it gets really fascinating, the connection between the psychological and the biological.
It's the ultimate bridge. We now just accept that all mental processes come from the brain.
So when a therapy like CBT works,
It's because it's causing actual physical changes in the brain.
Right.
Brain changes.
that leads us straight into the biological model, which says mental disorders often have physical causes.
And that model is the foundation for, well, almost all of our modern treatments.
Yeah.
From psychopharmacology to advanced brain stimulation therapies, things like ECT, RTMS, all those acronyms, they're all designed to physically rebalance the brain.
Okay, so let's shift to how this is all applied in, actual care settings.
Well, you have to start with the humanistic side. Maslow's hierarchy of needs.
Physiological, safety, love, and belonging.
Esteem. Self-actualization. For a nurse, this is not abstract theory. It tells you what to prioritize right now.
And in nursing specifically, you have to mention Hildegard Peplau.
Oh, absolutely. Her work on interpersonal relations and, crucially, her breakdown of the 4 levels of anxiety.
Mild, moderate, severe, and panic.
It's a roadmap for intervention. It tells you what to do and when.
And all of this seems to build toward what feels like the most current idea, the mental health recovery model.
This is the big paradigm shift.
Because it's not focused on a cure, is it? It's about adaptive living.
Exactly. It's about hope, empowerment, and finding coping strategies to live a meaningful life, even if some symptoms are still there.
And that recovery focus changes everything. It shapes milieu therapy, where the whole environment is part of the healing.
And it changes the goals of family therapy. The focus becomes improving communication and lowering conflict.
So we've really covered the whole landscape, from the internal world of the id and ego, all the way to brain chemistry and patient-led recovery.
It's a huge journey, but it leaves you with a pretty profound question, I think. If the main goal, the measure of success, shifts away from curing a disorder to ensuring empowered, meaningful, adaptive living,
Yeah.
then what does that really imply about our traditional definitions of sickness and health in psychiatry?
Yeah.
And, how might that change the very structure of how we deliver care?
Yeah.
What are we actually aiming for? Something to think about.
Okay, so let's jump right into this deep dive. We're looking at the legal and ethical lines around psychiatric care.
Right.
And really, our mission here is to understand when the state can justify what the courts have called a massive curtailment of liberty. I mean, involuntary commitment.
That's the core conflict, isn't it? It's this incredible balancing act. You have the individual patient's rights on one side.
And public safety on the other.
Exactly. And while ethics are the goal, the law is the rule, and you have to follow the law.
So how does the government even begin to justify that? There must be a process.
Oh, absolutely. It all starts with due process, fair procedures. And that leads right to this idea of the least restrictive alternative doctrine.
Meaning you have to take the absolute least drastic step possible.
Precisely. The Supreme Court really drove this home with the Olmstead ruling. It It basically forced states to look at community settings first, not just jump to locking someone in an institution.
Okay, but say admission is the only option. What's the criteria?
There are three main conditions that have to be met. First, there's got to be a medical justification, an actual illness.
Makes sense.
Second, that illness has to be causing an immediate crisis right now.
And third,
And third, there has to be reasonable expectation that going to the hospital will actually help with that immediate problem.
so once someone is admitted, that's where the tension really ratchets up, right? You've got the right to treatment, which guarantees humane care, an actual plan.
Yeah, but that bumps right up against the right to refuse treatment.
The big one.
It's huge. I mean, the whole idea of informed consent is based on an adult's right to self-determination.
Yeah.
You can say no. You can withdraw your consent at any time. The riskier the procedure, the more explicit that consent has to be.
But let's look at a case that really tests that. You brought up this scenario with a man named Bandy.
Yes. So Bandy is found in a cemetery. He's extremely agitated, and he's scrubbing shopping carts so hard his hands are bleeding. He's saying he has to get rid of all the rust in the world to be saved.
So the police bring him in, and that was legally okay.
It was. It was justified because he was clearly at risk for harm to self. You had the agitated state, the bleeding fingers. It met the standard.
Okay.
But here's the tightrope walk. The moment he's admitted, Bandy is chemically restrained. He's medicated against his will.
Whoa, hold on. We just established this huge right to refuse treatment. How is that not a complete violation?
Because the law carves out a tiny exception for a temporary emergency override. It's only allowed when the threat of imminent harm is absolute and immediate.
So it's a stopgap.
To stopgap, exactly. It followed legal protocol for immediate safety. But the second that immediate crisis is over, his right to refuse snaps right back into place for any future long-term decisions.
That is a razor-thin line.
Okay, shifting gears a bit. What about confidentiality? We all know it's fundamental, but there's the famous exception, the duty to warn.
The Tarasoff Doctrine.
Yes.
This says that if a therapist assesses a credible danger of violence, and they can identify a specific victim or victims, their duty to protect that person overrides patient confidentiality. They have to warn them. And this idea of accountability, it extends to colleagues too, doesn't it? Like between nurses.
Absolutely. A nurse has a legal duty to report a colleague if they see behavior that puts a patient at risk. And if talking to the person doesn't fix it, they have to go up the chain of command. It's part of their license.
So we've covered a lot. We started with this ideal, the least restrictive alternative, but then we see in a real case like Bandy's, immediate safety can mean involuntary actions like chemical restraint.
It does. And that brings us to the final thought for you to really mull over. Given that we have this legal requirement for an individualized care plan and this acknowledged right to refuse treatment, what specific information should be legally mandatory in a patient's discharge papers to ensure they're actually safe and cared for once they walk out that door, especially if they're going back to a really unstable situation? What does real continuity of care look like on paper? Okay, let's unpack this. We're diving into something that is really the absolute bedrock of psychiatric treatment.
It really is the therapeutic nurse-patient relationship.
Exactly. And it's this unique professional bond where, and this is the key part, right? Mutual needs are sort of forbidden.
Strictly forbidden. Yeah, that's our mission today, really. To understand the power and the boundaries of this relationship. Its whole purpose is helping patients grow.
Helping them communicate difficult things, promoting their own self-care.
Right. And to keep that focus, there's a structure. It's not just random.
A framework. We talk about the three main phases: orientation, working, and termination.
And they can be pretty fluid, often overlapping. And there's even that pre-orientation phase, which is just for the nurse, getting their own emotional house in order before anything even starts.
So let's draw that line right away. This is nothing like a social relationship, a chat with a friend.
Not even close. In a social chat, needs are met mutually. The conversation can be superficial. You might trade advice.
But the therapeutic relationship is completely different. The focus is 100% on the patient's ideas, their needs.
The nurse is actively using every communication skill they have. The language is direct, it's professional.
So this isn't just about being friendly.
No, it's about maximizing patient growth, which means the nurse has to set their own emotional needs completely aside.
And how do they sustain that? What does that look like in practice?
Well, you see it in the tangible behaviors. Consistency is huge. Active listening and creating an environment where the patient really sets the pace.
But just going through the motions isn't enough, is it? It's that internal compass, the core qualities. That seems to be where the real risk is.
Oh, absolutely. And that brings us to empathy versus sympathy.
Okay, break that down for us. People mix those up all the time.
They do. Empathy is crucial. It's like temporarily living in the other's world to understand their feelings, but you maintain your objectivity.
You're a visitor.
A visitor, exactly.
Yeah.
Sympathy is when you start to feel their pain. And that's a problem because you lose the distance you need to actually guide them.
You're no longer helpful at that point.
You're not. And you couple that empathy with genuineness and positive regard, real respect, suspending your judgments, and you have the foundation.
Yeah, okay, so this is where the boundaries can get fuzzy. We have to talk about transference and countertransference.
Yeah, these are the big unconscious projections that can really wreck objectivity.
So transference is when the patient puts their past stuff onto the nurse.
Exactly. They unconsciously displace emotional reactions from, say, a parent onto the nurse. They might suddenly say, "You remind me of my cold boss."
And countertransference is just the reverse. The nurse does it to the patient.
It's the nurse displacing their feelings. If a nurse gets consistently frustrated with a patient who struggles with authority, maybe because it mirrors the nurse's own issues with a parent, that's countertransference.
And they might not even be aware of it.
That's the key. It's unconscious, which is why self-awareness is so critical.
Okay, let's bring this to the practical side of things. In a clinical interview, what are some of the key guidelines? I hear they can be a bit counterintuitive.
They often are. The big ones are: speak
Okay.
briefly, focus intensely on the patient's feelings, the effect, and critically,
Avoid giving advice.
avoid giving advice.
Why is that so essential? Most people think that's the whole point of getting help.
It's what people think they want, but giving advice is actually detrimental. It promotes dependence. It stops the patient from finding their own solutions.
It undermines the whole goal.
Completely. The goal is independence.
Yeah.
So instead, the nurse uses what we call attending behaviors, body language, eye contact, verbal tracking, to create that safe space for the patient to do the work.
And that all circles back to self-awareness. Our sources really stress that to accept a patient's values, the nurse first has to understand and accept their own.
You have to. You can't be a blank slate if you don't know what's written on it first.
And the sources identify modeling, presenting a vivid example of values in action as a really powerful educational tool.
It raises an important question for all of us, really.
So here's a final thought for you to take with you.
Yeah.
Considering that, how often are you consciously modeling the behaviors you value in your own daily interactions?
Something to chew on. Welcome back to the deep dive. Today we're tackling something that's really critical in a lot of professional settings.
Absolutely. We're diving into a stack of sources that try to separate three concepts that get dangerously blurred all the time.
Anger, aggression, and violence. And for professionals, understanding the difference isn't just academic.
No, it's about immediate safety. The challenge is drawing those clear lines, even when social backgrounds can sort of change the definitions.
So is it fair to start by saying that anger by itself is never actually the problem?
That's a perfect way to put it. I mean, anger is just a normal emotional response.
To frustration or feeling threatened?
Exactly. It can be anything from, mild irritation to full-on rage, but it's an emotion and it doesn't need a judgment call on it.
But when that emotion turns into an action, that's when we get to aggression.
Yes, aggression is sort of anger's motor counterpart. It's a goal-directed action, a verbal or even a physical attack.
The sources are clear that aggression isn't always bad, right?
That's a critical piece of nuance for you to remember. It can be appropriate, like protecting yourself.
Right. So the real escalation we need to prevent is violence. How do we define that?
Violence is the unjust, unlawful display of force with the discrete intention of doing harm.
The intent, that's the key.
It's the intent to injure that really sets it apart.
Which is why something like bullying is so corrosive. It implies that persistent violence.
It's malicious behavior designed to humiliate. And the sources point out just how common this is, especially in places like healthcare.
The numbers are pretty shocking. We're talking 25 to 50% of nurses reporting bullying. But here's an interesting detail.
What's that?
The sources break it down. 50% of staff report that aggression comes from their peers.
Ah, yes. That's called lateral bullying.
Lateral bullying. And it's not just from peers. About 42% also report aggression from authority figures.
And it can be subtle things, too. Invalid criticism, taking credit for someone's work, even just, public eye rolling.
Okay, so let's pivot from that environment to predicting an immediate crisis. What's the strongest long-term predictor that someone might become violent as an adult?
The research is very, very clear on this. It's childhood aggression.
Things like setting fires or animal cruelty, those kinds of red flags,
Those are
right?
the major ones, yes. They are significant predictors for adult risk.
But what about right now? In a clinical setting, what's the single most important predictor of imminent violence?
This is the key insight for anyone on the front lines. It's
Yeah.
one word: hyperactivity.
So, not shouting, not threats, just movement.
Observable restlessness, pacing, slamming doors, just that high motor activity. That is the most consistent and immediate warning sign.
And there are other physical signs to look for.
Oh, absolutely. Things like a clenched jaw, a rigid posture, a voice that gets really loud or sometimes goes very soft.
Or even stone silence.
Right. And of course, the environment itself can play a huge part. Overcrowding, staff, inexperience, they can make things worse.
So knowing those signs tells you how to intervene. In that pre-assaultive stage, the goal is de-escalation.
It's all about communication. Your body language has to be non-confrontational. Stand at a 35-degree angle, use a soft voice.
And set clear, enforceable limits.
You have to. Something like, it's okay to be angry, but it is not okay to threaten people.
The research also mentioned a powerful question to ask.
What will help now? It's simple, but it can completely change the dynamic by giving back a sense of control.
But if things do escalate to the assaultive stage, that's when more restrictive interventions come in.
Right. Medication, seclusion, restraint. But, and this is a huge but, only when there's a clear and present danger to self or others.
And you always try the least restrictive option first.
Always. And honestly, the evidence is pretty damning on things like seclusion and restraint.
They have no therapeutic value, right?
None. And they cause profound harm. The sources cite about 150 deaths a year linked to these methods.
Wow. Which is why the whole practice is shifting.
Thankfully, yes. We're seeing better alternatives being researched, like comfort rooms, where someone can go voluntarily to self-manage.
Or that broader trauma-informed approach.
Exactly, focusing on principles like safety, trustworthiness, and empowerment, not just rigid procedures.
So to sort of wrap up our deep dive today, getting the distinction between anger, aggression, and violence right.
And immediately spotting those physical warning signs like hyperactivity.
It's just absolutely crucial for professional safety and for providing responsible care.
Couldn't agree more.
And finally, one last thing the sources really emphasize is staff self-care and self-knowledge. Knowing yourself stops you from making impulsive, emotion-based responses.
That might be the most important piece of all.
So the final thought we want to leave you with is this. How well do you know your own personal triggers and your nonverbal communication when you're confronted with hostility? What is your current strategy for self-care in those high-stress situations? Something to think about. We'll see you next time. Okay, let's get into it. Today, we're doing a deep dive into a really specialized area, psychiatric disorders in children and adolescents.
Right. And what we're trying to do here is pull out the most critical insights from the material, the prevalence, the theories, and how we actually assess and intervene.
And the numbers right off the bat are just staggering.
They really are. The material points to a prevalence of up to 21% in young people from ages 9 to 21.
21%, that's 1 in 5.
Exactly. And what's even more alarming is this care gap. Only about a fifth of the kids who need mental health services are actually getting them.
That is a huge disconnect. And the sources say comorbidity is basically the norm, right? It's rare for a kid to have just one single diagnosis.
Oh, absolutely. It's almost expected. So if we know what the problem is, the next question is, why? What are the risk factors?
Yeah, what's the theoretical mix here?
Well, it's always a mix. You have genetics, you have neurotransmitter imbalances, but a huge piece of the puzzle is temperament.
And temperament isn't personality, it's something more foundational.
Precisely. It's the inborn way a child engages with the world. Things like persistence, their activity level, how they adapt to new situations. There are 9 areas, and they set a kind of baseline.
And then there's the environment, which brings us to the ACE score. I see this mentioned everywhere. What exactly is it measuring?
ACE stands for Adverse Childhood Experiences. So it's a score that it quantifies exposure to trauma.
Things like abuse, neglect.
Right, or even major household dysfunction. A high ACE score is a really powerful predictor for future health problems, both mental and physical. It's a non-negotiable part of any assessment.
Which makes sense. So because kids are constantly changing, you can't just use an adult assessment model, can you?
Not at all. It would be completely inadequate. With kids, everything has to be framed within their developmental stage.
So it's more holistic.
It has to be. You look at family history, the ACE score, of course. And for teenagers, you have to get very specific. You have to ask directly about substance use, sexual activity, self-harm, suicidal thoughts.
But what about a 3-year-old? How do you get reliable information when they can't sit for an interview or even explain how they feel?
You have to enter their world. You use games, you use drawings, puppets, free play.
So it's more about observation.
100%. You watch how the child interacts with their caregivers, with their siblings. That relational data is just as valuable as anything they could tell you.
Let's focus on a couple of specific disorders. Autism spectrum disorder, or ASD. We know it involves social deficits and rigid behaviors. How do the severity levels work?
The levels are really for planning interventions. So level 1 means you see noticeable deficits, but their language might be pretty normal.
Okay.
But level 3 is severe. We're talking profound deficits. Communication is often just about basic needs, and the key is catching it early.
The sources mention early signs like not liking to cuddle or poor eye contact.
Exactly. Those can lead to a diagnosis between 2 and 3 years old. And that early intervention is linked to a much, much better prognosis.
Okay, let's switch gears to ADHD. The stereotype is a kid who can't stop fidgeting. What's the biggest misconception there?
That it stays that way.
Yeah.
The physical presentation changes completely as they get older. In kids, yeah, you see the hyperactivity, the constant talking and moving.
Right.
But in adults, that physical energy often turns inward. It becomes a feeling of internal restlessness, a difficulty focusing, but not necessarily running around the room.
That makes it so much harder to spot. So once there's a diagnosis, what do interventions look like? You mentioned it takes a whole team.
Absolutely. You need a developmental pediatrician, a school psychologist, specialized therapists. In schools, we use things like IEPs, individualized education plans, to make sure they get the right support.
And what about specific behavioral therapies for something like Tourette's?
For motor disorders like Tourette's, there's a therapy called CBIT.
CBIT?
Yeah, Comprehensive Behavioral Intervention for Tics. That's a kind of habit reversal training. You teach the person to replace the anti-tic with a different, less noticeable movement. It's highly specialized.
Wow. And what about for trauma, like reactive attachment disorder, when a child has had really inconsistent care early on?
There, the focus is all about rebuilding trust and their personal story. So you use family therapy, and the sources highlight things like bibliotherapy.
Using books.
Yes, using specific books to help them process their experience. And you also help the child build a narrative, a story of their life, which can be incredibly healing.
So the big takeaway here for you, the listener, is that this work requires a really integrated multidisciplinary team. There's no single magic bullet.
That's right. It's a toolkit play therapy, CBT, CBIT, constant caregiver involvement. Which brings us to a final thought to leave you with.
Okay.
When you're assessing a 16-year-old who's abusing a substance, let's say something like aerosol paint, what's the one psychological factor you have to explore that's different from an adult assessment?
And the answer is so critical for managing risk. The material is very clear on this. You have to explore the presence of distorted perceptions of invincibility, that very teenage belief that it won't happen to me, that they're immune to consequences. It changes everything about how you approach intervention and safety.
Okay, let's jump in. For today's deep dive, we're trying to get a fast, clear handle on serious mental illness, or SMI, and not just what it is, but how its impact kind of ripples out into other major adult health issues, things you might not connect, like ADHD or even sleep.
Right. And to do that, we have to start with the definition, because people hear mental illness and it's a huge category. We call that AMI, any mental illness.
But SMI is different.
It's very different. SMI is specifically defined by serious functional impairment. So it's an illness that substantially limits your ability to function in at least one major area of your life.
Like holding a job or...
Exactly. Holding a job, managing your finances, even just your relationships. That limitation is the key.
And the cost of that limitation is, well, it's massive. Our sources were saying the annual societal cost of SMI is right up there with heart disease.
It's a staggering number, and it's driven by these really stark individual outcomes. We're talking premature death, stigma, and a much higher chance of ending up incarcerated.
Which brings us to the families, the caregivers.
Yeah.
They're on the front lines of this.
They absolutely are, and the burnout is immense. But is that just from the illness itself? Or is it the system they're fighting?
Well, the sources really point to the system. The illness is hard, of course, but the frustration often comes from battling a system that, just doesn't work.
This is where it gets, frankly, brutal. The source material had that example of Mr. A.
Oh, that was a tough read.
Right. He's imprisoned for an assault because he was hearing a voice. He gets moved to a state hospital, which seems like the right step.
But then the hospital closes.
The hospital closes, and he goes right back to prison. That's it.
That's a perfect, if tragic, example of what they call the criminalization of the mentally ill.
It is. It's a process. It's deinstitutionalization followed by what we call transinstitutionalization.
So moving from one institution to another.
Essentially, yeah. You're just transferring the responsibility for care from the healthcare system right over to the criminal justice system. And this whole cycle is often made worse by clinical factors. One in particular is anosognosia.
Okay, that's a critical term. Let's not gloss over that. What does that actually mean for a patient?
Anosognosia is a neurological condition. It's a change in the brain that makes it impossible for someone to recognize that they are ill.
So it's not denial.
Not at all. It's a lack of insight. And you can see how that makes treatment adherence, almost impossible without a huge amount of support.
Which is why the sources are so clear on this one point. Caregivers must never, ever blame or shame someone for non-adherence.
Absolutely not. The focus has to be on support, on evidence-based models like assertive community treatment or ACT.
Where you're providing care out in the community, not just in an office.
Exactly. Medication, skills training, crisis support.
Yeah.
You meet them where they are.
These kinds of functional problems, they're not just in SMI. We see echoes of them in conditions that people often dismiss, like adult ADHD.
Oh, for sure. It's so underdiagnosed, and the long-term outcomes are serious. We can actually measure them.
What does that look like?
Well, you see adults with ADHD achieving a lower socioeconomic status, higher rates of, say, nicotine or alcohol use, and what's really concerning for public safety, more traffic incidents.
More contact with the police, too.
Yes. It's a deficit in regulation that has these direct, real-world consequences.
And that leads us to the last and maybe the most widespread issue in our sources. Sleep. Or the lack of it.
Yeah, and we're not just talking about a bad night here and there. Chronic insomnia affects about 1/3 of all people, 1 in 3.
That's a huge public health issue.
It's massive. And what's wild is that somewhere between 15% and 30% of us are just operating with insufficient sleep all the time, less than 7 hours a night.
And that's not just about feeling tired.
No, not at all. It contributes directly to major physical problems, obesity, diabetes, cardiovascular disease. But the immediate risk, the acute risk.
Accidents.
Exactly. Impaired judgment, lower vigilance. It's especially dangerous for night shift workers, in healthcare, public safety. One moment of fatigue there can be catastrophic.
So when you pull it all together, you have this massive systemic failure with SMI, the chronic functional costs of things like adult ADHD, and then this pervasive danger of sleep loss.
We're all connected, different parts of one giant, very expensive public health problem.
A problem of function and safety.
Which leads to a final thought for you, our listener, to consider. We know some disorders are quite rare, right? Narcolepsy, for instance, affects maybe 79 people out of 100,000.
Very.
But then you have something like insomnia, which affects 1/3 of everyone. So here's the question. If we really want the biggest, fastest reduction in the societal cost burden we've talked about today, how much could we gain by just prioritizing the widespread treatment of these pervasive, often minimized conditions like sleep disorders or adult ADHD? It's something to think about.